professor in the Department of Hematology, AIMS New Delhi. And the faculty who's going to present the talk is Dr. Ruchi Gupta ma'am. She is a professor in the Department of Hematology, SGPGI Lucknow. The moderators for today's event are myself, Dr. Ifat Jamal, Associate Professor, Department of Hematology at IGIMS Patna, and Dr. Rajesh Mishra sir, who is a consultant pathologist at DWH Hamirpur. The webinar hosts for today are Dr. Anita Borges ma'am, consultant pathologist, Center for Pathology, Tata Trust Mumbai, and Dr. Sumit Gujral sir, Professor, Department of Pathology, Tata Memorial Hospital, Mumbai. There are some reminders. As in cases of connection interruption, low or no sound, video freezing, or video lag, kindly leave the meeting and rejoin with the same link. If the problem persists, please check the internet connection. Please answer the poll questions by typing in the chat box, and please do not send requests for annotations to the presenters. These are some of the disclaimers. Few more. The upcoming talks are, the next talk is a slide seminar actually. It is on the coagulation studies, and it is by Dr. Naveen Kakkar sir from MNC Sweden on 6th of June, followed by another talk on common stains in hematology by Dr. Ganesh sir on 11th of June. So without any further delay, let's start the session. I will request Dr. Ruchi ma'am to kindly start the presentation. Over to you, ma'am.
Thank you, Dr. Ifat. So I'll share my screen, and at the outset, I'd like to thank the chairperson and moderator. Thank you, Dr. Ifat, for such a kind introduction. Is my screen visible?
Yes, ma'am. It's visible.
So the topic which we'll be talking about in the next 1 hour is approach to thrombophilia. So we frequently talk more about the bleeding disorders and how the coagulation cascade starts with the intrinsic pathway and the extrinsic pathway and terminates in the formation of a fibrin clot. But let's just talk about how this pathway is regulated, and even lesser we talk about the fibrinolysis part, which ensures that the clot which is formed is restricted to the area where it is supposed to be. So there's a very delicate balance between this coagulation cascade, the anticoagulant pathway, and the fibrinolytic pathway, and an error at any particular stage can tilt this delicate balance to either ways, either into a bleeding disorder or it can predispose to a state of thrombophilia. So before we actually go on to the factors which are responsible for thrombophilia, I believe it is important to understand the coagulation cascade, which I'll do in the next 3 or 4 slides. And this is a beautiful image of a cascade, and it actually represents how the system works in our body. This is kind of a borrowed idea from Dr. Dinesh. So if we look at the cell-based model of coagulation, there is an initiation phase which starts with the expression of the tissue factor when there is an endothelial cell injury, which this tissue factor interacts with factor 7A, and then this leads to the formation of extrinsic 10A, and factor 10A is produced. Simultaneously, a small amount of factor 9A is also produced. So this is actually a link between the extrinsic pathway and the intrinsic pathway. Subsequently, in the extrinsic pathway, there is formation of the extrinsic there is formation of the prothrombinase, because of which a small amount of thrombin is produced. This is known as the thrombin part. Once this thrombin is produced, it activates multiple downstream pathways of the intrinsic pathways, that is 9, 11, 8, 5. These are critical for the activation of the intrinsic pathway. And subsequently, in the cell-based model, if we see as the amplification phase, where activation of the 11A again subsequently leads to the downstream activation of 9A, which interacts with factor 8, which was activated by thrombin. This forms the intrinsic 10As. Now again, factor 10 is activated. Factor 5 is activated again because of thrombin. And now what is formed is a much larger amount of thrombin, which is known as the thrombin burst. So this thrombin is now sufficient to convert fibrinogen to fibrin, and we have a very strong and a stable fibrin clot which is formed. This thrombin is not only responsible for this conversion of fibrinogen to fibrin, but it also activates factor 13. And this factor 13 cross-links this clot and forms a very stable clot. So this is how the coagulation cascade begins, and a fibrin clot is being formed physiologically. What regulates the intrinsic pathway? Now that thrombin has been formed, उसको कोई तो check करने वाला चाहिए. So that thrombin बना उसने 9, 10 सबको activate कर दिया, fibrin convert कर दिया, thrombus बना दिया. This thrombin interacts with thrombomodulin and activates protein C. This protein C is now in the presence of the endothelial protein C receptor, gets converted into activated protein C. This activated protein C acts on 8A and 5A and breaks them down. So जो आगे cascade continue करने के लिए जो आपको important cofactors चाहिए थे, that is 8A and 5A, उनको block करा activated protein C ने. So it is blocking 10As as well as the prothrombinase, and thus reducing the amount of thrombin which is being formed. Further, APC also interacts with the EPCR and reduces the activity of the PAR1 receptor, that is the receptor on the platelet surface. So it is also kind of subduing the platelet activation. Further, thrombin, the major regulator जो है वो है antithrombin. So antithrombin not only blocks thrombin, but it also blocks factor 11A, factor 10A, and to some extent other factors like factor 9A. So this is how the intrinsic pathway is kept under check. Similarly, if you look at the extrinsic pathway, tissue factor expression की वजह से there was an interaction with factor 7A, due to which factor 10A was formed. This is restricted by the tissue factor pathway inhibitor. It has there are 2 moieties tissue factor pathway inhibitor alpha and beta, and they can interact with the active binding sites of factor 7A as well as 10A. And then subsequently what happens is that thrombin पे एक check है. So this is how a regulation of the intrinsic and the extrinsic pathway occurs. अब जो clot बन गया था उसको कौन restrict करेगा? So that is the fibrinolytic pathway. For the activation of the fibrinolytic pathway, we have tissue plasminogen activator, urokinase plasminogen activator, which is again these are the factors which are produced from the endothelial cells or from the hepatocytes, which act on plasminogen and which gets converted into plasmin. This plasmin is also has a positive feedback loop on its own activators. और जो thrombin की वजह से हमारा fibrinogen to fibrin convert हुआ था, it is broken down into fibrin degradation products by this plasmin. So this fibrin clot is now getting restricted to the site of injury. But ऐसा नहीं कि ये clot lysis भी uncontrolled चल रहा है. इसको भी रेगुलेट करने के लिए आप plasminogen activator inhibitor 1. So जो plasminogen activator जिसकी वजह से plasminogen activate हुआ था, उसको भी check में रखने के लिए you have a plasminogen activator inhibitor 1. Similarly, you have calcitonin and factor 12, which has a negative impact on plasmin. And then you have non-specific inhibitors like alpha 2 antiplasmin and alpha 2 macroglobulins, which also try to keep plasmin under check. Thrombin ने खाली इतना ही नहीं किया था, thrombin ने अपना एक और factor भी activate किया था, that is thrombin activable fibrinolysis inhibitor. So it is also trying to stop कि fibrinolysis नहीं हो. So what I mean to say is that there is an interplay of multiple factors in coagulation, which ensure that this entire delicate balance is maintained, it is under check. And I'm sure it is evident कि किसी भी चीज का over expression होगा तो एक procoagulant state हो जाएगी, किसी चीज की deficiency हो जाएगी तो we might have a hypercoagulable state. So to me it seems something like this, that the thrombin was the main villain which converted fibrinogen to fibrin. उसको stop करने के लिए we had this tissue plasminogen activator which converted plasminogen to plasmin and cleave the clot. But कोई भी ज़्यादा जरूरत से आपने आपको ज़्यादा phantom ना समझे, उसको check करने के लिए you have antithrombin and again the tissue factor pathway inhibitor. Then to stop the plasminogen activity, you have the plasminogen activator inhibitor. And then thrombin itself, it's kind of it commits a self-suicide because it also activates protein C and partly protein S, because of which factor 5 and 8A are clean, and thus it ensures that uncontrolled coagulation doesn't go on. And if there is an error in this entire system, then that can lead to a hypercoagulable state. This thrombophilia can be basically it is a pathological state of exaggerated coagulation. It can be a venous thrombosis or an arterial thrombosis. बचपन से पढ़ते आ रहे हैं, जब भी thrombosis बोलते हैं, so we say that there are causes of venous thrombosis and there are causes of arterial thrombosis. But eventually those causes are slightly different. But the risk factors like smoking, hypertension, obesity, they are kind of common. जब भी हम thrombophilia या inherited thrombophilia की बात करते हैं, तो we are usually referring to venous thrombosis. That is, we are worried about the deep thrombosis in the areas like the deep veins, the pulmonary thromboembolism, unusual site venous thrombosis like the mesenteric veins or the thrombosis in the hepatic veins. Whereas when we talk about the arterial thrombosis, it's like MI and stroke, which are usually atherosclerotic induced and they are platelet-rich plaques and platelet-rich clots. Arterial thrombosis में usually हम thrombophilia और rather inherited thrombophilia testing की बात नहीं करते. There are some conditions like APLA, PNH, maybe even JAK2, जिसमें कि there is an overlap and they can present both with venous or arterial thrombosis. So the distribution is slightly arbitrary, but yes, whenever we are talking about thrombophilia or inherited thrombophilia, I would emphasize we are usually referring to a venous thrombosis. And way back in 1850s, this Virchow's triad was proposed by Rudolf Virchow, wherein he emphasized that there are three factors in our body that predispose to the development of thrombosis. This includes stasis, then you have the vessel wall injury, and then you have the hypercoagulability. This hypercoagulability basically can be due to inherited causes or it can be due to acquired causes. Usually it is a combination of acquired and inherited causes which eventually leads to a thrombophilic state. So this is the list of the usual inherited causes of thrombophilia which we look for. There is a loss of function, basically यानी कि protein C and protein S का काम है कि factor 5 और 8 को block करना. If there is a deficiency, so that blockade does not occur and there is an uncontrolled procoagulant status. Similarly, antithrombin or in fact antithrombin 3 की जगह आजकल antithrombin is more commonly used. So अगर उसकी deficiency हो जाएगी तो thrombin पे कोई check नहीं रहेगा. Then we have some gain of function mutations like factor 5 leadin. So factor 5 leadin is such a mutation जिसमें कि protein C factor 5 को cleave नहीं कर पाता है जो normally इसको cleave कर लेना चाहिए था. Similarly, there is a prothrombin gene mutation. Again, this is a gain of function mutation because of which the prothrombin amount which is there is produces more. Then there is a situation like you can have higher levels of factor 8, 9, 11, fibrinogen and bond factors. So in नीचे वालों का eliminated factors का थोड़ा people have shown that they have been found in patients with thrombophilia, but these are not things which you specifically test for in a patient who has had an episode of thrombosis. Then besides these, there are other genetic abnormalities like mutation of the methylene tetrahydrofolate reductase or hyperhomocystinemia, dysfibrinogenemia, rarer ones being plasminogen deficiency and plasminogen activator inhibitor deficiency. So मैंने pathway इसीलिए बताया so that you can understand where plasminogen and plasminogen activator inhibitors coming into role or play, so and how they are predisposing to thrombosis. Then there is a long list of acquired causes besides the inherited causes. So a major surgery, prolonged immobilization, pregnancy, use of estrogen replacement therapy, APLA syndrome, PNH, malignancies, solid or hematological. In hematological malignancies, if you actually look up literature, so almost all sorts of hematological malignancies, maybe leukemia, lymphoma, myeloma, everybody of them have a risk for 2% to up to maybe 15 to 20% risk of developing a thrombosis. Then we know of HIT, then we know myeloproliferative neoplasms, nephrotic syndrome because there is a loss of certain anticoagulant proteins, so that is why that also leads to a procoagulant state. Smoking, diabetes, atherosclerosis are all that contribute to the endothelial injury and thus indirectly contribute to thrombophilia. And then you have these hyperviscosity syndromes like polycythemia vera, Waldenstrom macroglobulinemia, sickle cell disease, etc. So this is a list of the common inherited and acquired states which can lead to thrombophilia. So if you actually look at the prevalence of these abnormalities like protein C, protein S, antithrombin deficiency, अगर हम general population में बात करें तो incidence is not very high. It is higher if you do an unselected VTE patients में incidence अगर हम देखें तो it is definitely higher. So, but we are really not bothered about their incidence here because हम कोई general population को पकड़कर deficiency के लिए screen नहीं करते हैं. The problem is that people who have this deficiency, the relative risk of first episode of VTE is much higher in these individuals as compared to the normal individuals. Further, there is also an increased risk of recurrent VTE in these patients who have a thrombophilia. Meaning thereby कि जिन लोगों में इसकी protein C, S या antithrombin या factor V mutation होगी, उन patients में there are chances that the rate of recurrence would be higher. But there is not an absolute correlation. I don't want the audience to go back with the thought कि अगर direct correlation है कि अगर deficiency है तो recurrence है. क्योंकि thrombophilia testing से लोगों ने देखा है कि जरूरी नहीं है, but yes, it is a risk factor and there is a relatively higher risk of recurrence if there is a documented deficiency or an abnormality in any of the abnormalities which are listed over here. So what next? हमें पता चला coagulation cascade कैसे काम करता है, उसको कौन चेक करता है, inherited causes होते हैं, acquired causes होते हैं, stresses हो जाए, endothelial injury हो जाए, इन सबसे thrombosis हो जाता है, right? So we know the basics, we know many factors are involved. There can be some inherited factors, there can be some acquired factors. Now how to apply all of this knowledge practically when we are dealing with a patient who's come to us with thrombosis? So suppose these are three hypothetical case scenarios. You have a 55 case one is a 55-year-old male, past history of hypertension. He's recently undergone major surgery and there was a pelvic fracture and day 21 post-op he developed a distal deep vein thrombosis. He started on anticoagulation therapy and then referred for an outpatient assessment. So do we need a thrombophilia testing in this patient? क्या हमें इसको करना चाहिए screen for inherited thrombophilia? We have a case scenario 2 where we have a pregnant female G1, T0 at 32 weeks of gestation and she has developed left leg DVT and presenting with a 2-day history of increasing left leg swelling and pain. Again, she started on anticoagulation and referred for outpatient assessment. Does this patient need thrombophilia testing? So मैंने कोई poll questions डाले नहीं, so इसलिए I'm sorry, I am not really asking you. This is a way of teaching. I'll try to present how these case scenarios have to be addressed. And then if we see case scenario 3, it's a 25-year-old male, meaning that he's a young male with chest pain for past 3 months. There's no past otherwise history. By all imaging techniques, it was confirmed that the patient has acute PTE. He was started on anticoagulation. Now what? Should we test him? Should we not test him? How do we decide? Patient को 3 months का ही anticoagulation देना है, 6 months का देना है या lifelong देना है? और अगर देना भी है तो क्या देना है? So before somebody, a physician, raises a form for thrombophilia testing, there are some things or these basic questions I would suggest that one should answer. To test or not to test? If yes, you have to test. When is the time to test? What are the tests you have to do? And what is the impact of the test which will, actually going to happen, which will impact the management of the patient? So ये कौन बताएगा हमको? So there are a lot of guidelines. There is the American Society of Hematology 2023 guidelines for management of venous thromboembolism and thrombophilia testing. Then there is a British Society of Hematology guidelines. Then there is also American Chest Society ACCP guidelines. So if you look at these guidelines and if you go through these guidelines, there are a lot of recommendations which are given. कि ऐसा हो तो ऐसा करना है और ऐसा हो तो ऐसा preferably नहीं करना है. And the level of recommendations are like 1, 2, and 3. And some are recommendations which have to be followed based upon the discussion between the treating physician and the patient. And you cannot just put the patient on a lifelong anticoagulation just like that. So overall, the purpose of these guidelines is to develop recommendations whether thrombophilia testing will improve patient outcome and where are those situations where actually thrombophilia testing should be done. So एक चीज हमें हमेशा याद रखनी है कि the crime has already been committed, meaning thereby कि जब patient हमारे पास lab में refer होता है thrombophilia testing के लिए, at that time point usually thrombosis has already occurred. So what, and the physician has already given the immediate treatment जो उसको initiate करना था, that he has started the anticoagulation of the patient irrespective of the cause which has led to that thrombosis. So thrombophilia testing is basically required in specific situations which will impact management, which will help us to decide कि drug हमें ये नहीं ये देना है, या it will help us to predict risk of recurrence to some extent. For example, अगर अभी thrombosis हो ही गया है और अगर protein C deficiency patient को है भी, तो मेरा initial treatment change नहीं होने वाला, तो इस समय टेस्ट करने से कोई फायदा नहीं है. So the basic testing strategy, which is integrated with how to test and with management, states that if it is a provoked thrombosis meaning that कि अगर आपको पता है कि patient has undergone a major surgery and he's been bedridden, or there are other strong risk factors because of which the patient has developed thrombosis, once that risk factor is removed, the risk of VT recurrence is very low. So ऐसे patient में test करने का कोई मतलब नहीं है, because you already know कि thrombosis probably इस कारण से हुआ है. You will eventually treat them with short-term anticoagulation and let the patient off the hook. Similarly, दूसरा extreme है कि it is an unprovoked thrombosis. So you really don't know what was the reason because of which the patient has come, a healthy and otherwise asymptomatic individual come to you with an unprovoked reason for thrombosis. इसका मतलब the risk of VT is usually high, recurrence is high. So ऐसे patient में आपको extended anticoagulation देना ही पड़ेगा irrespective of your test result. अब इसमें protein C deficiency आए या नहीं आए. This is my understanding on the topic. If Mukul would like to differ from me, Mukul, anytime point please correct me. So this is actually what the new ASH 2023 guidelines suggest, that if it is a provoked thrombosis, do not test because the risk of recurrence is low. You will anticoagulate for a short time and leave the patient. If it is an unprovoked thrombosis, the risk of recurrence is very high. You have to immediately go ahead and anticoagulate the patient. इसलिए testing से कोई added advantage नहीं है. Though maybe in clinical scenarios or situations, even in these situations, people do test for inherited thrombophilias. ज़्यादा important role they have said is when it is an unusual site thrombosis, where you are really not sure of the risk of recurrence. You can go with two ways of testing strategies on management. You do not test and give extended anticoagulation to call, या you test and then take a call कि अच्छा इसमें ये risk factor है, इसीलिए हमें extended anticoagulation देना चाहिए. And again, if it is a provoked thrombosis in the presence of minor risk factors, then again the risk of recurrence is intermediate, and the testing strategy would depend upon the treating physician, and it might vary from stopping anticoagulation after 6 months, or it may go on for a very extended or a longer phase of anticoagulation. I hope कि मैंने आपको किसी को confuse नहीं किया, and I'm clear in what I'm trying to put across, that if it is a provoked thrombosis, there is no need of testing. If it is an unprovoked thrombosis, you can test for certain things, but the risk of recurrence is very high, and your management would also may or may not depend upon the test results. So coming back to the case scenario 1, where I said that it was a 55-year-old male who had undergone major pelvic surgery and had developed PVT on day post of 21. So if you look at the strong risk factors which predispose to thrombosis, a fracture of the hip or leg or a knee replacement surgery or a major surgery in general anesthesia, or anything following major trauma where the patient has been bedridden or in the hospital for more than 30 days, then these are all strong risk factors which can predispose to thrombosis. Iसीलिए the general recommendation is do not test for inherited thrombophilias if there is a presence of these known strong risk factors. Right? So this is the first lesson of the talk, probably approach to thrombophilia में, that if you know there is a very strong risk factor, please do not test. इस ऐसी situation में test करने का कोई मतलब नहीं है. So कहाँ test करना चाहिए? So it is usually recommended that you should test if there is a thrombosis in a younger individual, younger meaning thereby age less than 50 years. If it is an unusual site, if there is a recurrent VTE, if there is an unexplained arterial thrombosis, then you have rare events like neonatal purpura, neonatal purpura fulminans without sepsis, or you have recurrent or unexplained pregnancy losses like we have in APLA. So these are more specific situations where if you read the articles, these are the consistent situations where it is recommended that you should test. So that helps us to solve case scenario 2 and case scenario 3 में हमें thrombophilia testing करनी है. तो टेस्टिंग तो करनी है. अब नेक्स्ट क्वेश्चन है कि हमें क्या टेस्ट करना है और कब टेस्ट करना है. So when to test? Ideally, all evaluations should be postponed after 3 to 6 months of an acute VTE, or when this acute management of the acute VTE is over. Clot-based or even antigenic assays for protein C, etc. should not be performed during acute VTE, as their levels may be low, it may be normal, even during pregnancy their levels may be normal, or when the patient is on AC OCPs, or when the patient is on anticoagulant therapy. In तीनों चारों condition में please do not test. And as I said, you can ideally postpone the testing to after 3 to 6 months, because anyways patient को हम 3 to 6 months के लिए अभी anticoagulate करने ही वाले हैं. अगर हमने प्रेगनेंसी के दौरान टेस्ट भी करा है, आइडियली हमें नहीं करना चाहिए, बट अगर हमने करा है तो we should repeat the test 2 to 3 months after pregnancy to confirm our findings. Normally, again, as I said, if the patient is receiving any kind of anticoagulant therapy, you should not test. But still, there are some situations where you might need to test. और अगर ऐसा करना पड़ता है, then vitamin D anticoagulant should have been stopped for at least 2 weeks. DOACs should have been stopped for at least 2 days or slightly longer. And if you're talking about low molecular weight heparin, then that should have been stopped for 24 hours. Or maybe you can just collect it before giving the, suppose आज morning dose दिया है, तो next morning dose देने से just पहले you can collect your sample. So for example, if I tell you DOACs has to be stopped for 2 days, so I still remember a patient of PTE who was referred for workup of mucus anticoagulant, and the LA came out to be positive. So when you consulted your physician, पता चला कि patient is on rivaroxaban. So rivaroxaban is a known drug which can lead to a false positive LA because it acts on factor 10. So if the clinician does not tell you that ये दवाइयाँ चल रही हैं, then आपके test results are meaningless. Right? Another important thing is never stop any treatment in between for testing. Right? Vitamin D anticoagulant stop करा मैंने after 3 to 6 months of therapy when the physician decided yes, we can keep the patient off the drug and let us switch him to low molecular weight heparin. इस दौरान इसकी हम testing करा लेते हैं. ऐसा नहीं कि acute thrombotic event में ही अभी हमने बंद करके दवाई और हम टेस्ट करा रहे हैं. Right? But there are some tests which can still be performed in the acute stage, like any kind of a genetic testing can be done. So factor V latent mutation, prothrombin gene mutation, MTHFR gene mutation, JAK2 gene mutation, even PNH testing, and antigenic assays like anticardiolipin और antiviral अगर हमें करना है for when we are suspecting APLA, तो ये हम acute event के दौरान कर सकते हैं. But even APLA workup में we will not test for lupus anticoagulant. Then the third point is what to test. So हमें पता चल गया कौन सी सिनेरियो है जब हमें टेस्ट करना चाहिए, हमें कब करना चाहिए, हमें समझ में आ गया कि हमें एक्यूट स्टेज में नहीं करना है, दवाइयां बंद करके नहीं करना है. When the acute event is over, हमें तब करना है. If the patient is on anticoagulant therapy, उस टाइम पर भी हमें नहीं टेस्ट करना है, right? So eventually when we are testing, what do we want to test? So the testing, general testing would be like you evaluate or work up any other patient in a hospital. You need to do a complete blood count with a peripheral smear examination. There could be an underlying hematological malignancies like polycythemia, leukemia, lymphoma, APML, or I still remember a patient of acute leukemia who had come with renal vein thrombosis. So things like that. So if you are suspecting a hematological malignancy, myeloma, तो वो सब routine workup will continue besides these basic things like liver function test, renal function test. Liver function test, why? Because सारे protein C is antithrombin, ये सारे factors they are produced in the liver. So if there is any reason because of which there is a liver dysfunction, their levels can be abnormally low. So we should know before we sign out our reports. Then the baseline population tests which include PT, APTT, TT, D-dimer, etc. This will actually tell you कि patient अभी acute thrombotic event में तो नहीं है अगर आपके clinician ने आपको नहीं बताया तो. Then as I said, additional testing on the clinical basis, what you are suspecting, हो सकता है कहीं imaging करने की जरूरत पड़े, कहीं पे आपको angiography करने की जरूरत पड़े, and so on to establish that there has been a thrombosis. And हमारे पास usually at the end में वो आएगा if there is no specific reason where, and then they want to work up for the patient for thrombophilia. So we'll do specific tests for thrombophilia. I'd just like to take a minute to emphasize because we are a referral center here at SDPGI and frequently what we see कि जो मेडिसिन का रेजिडेंट है उसको कई बार ये भी नहीं पता होता कि कौन से वैक्यूम में सैंपल भेजना है. So वो हमारे पास लिख देगा कि सैंपल पेशेंट रेफर फॉर thrombophilia worker protein CS and what he'll do is he will send us all 3 vials, a citrate, a plain and a DDA कि आपको जो ठीक लगे वो आप ले लो. So I think this is something which you should know. All population assays चाहे आपको thrombophilia testing के लिए protein CS, antithrombin कुछ भी कर रहे हो, so we need a 3.2% sodium citrate sample. All genetic testing can be done on an ETA sample and naturally जो आप antigenic assays करते हैं like cardiolipin and anti-beta उसके लिए you require a plain vial. So this I assume that the audience is well read and they know कि कौन सा sample और कौन सा test के लिए हमें what kind of an anticoagulant is required. So coming back to basic tests for thrombophilia. So जैसे मैंने बताया there are inherited and acquired causes. So protein C, S, antithrombin deficiency, factor V laden, prothrombin gene mutation. These are the common things which are tested in a lab normally when you send a patient for hypercoagulable worker. Elevated factor levels कुछ लोग अभी भी भेजते हैं but it is not usually recommended. As per the British Society guidelines which I just pointed out before, उनके recommendations में it is written that individual factor levels are not, it is not recommended to do individual factor levels to ascertain thrombophilia status. Then you have rare causes like fibrinogenemia, plasminogen deficiency, etc., which are I would say still being done in some very in some rare lab or very highly specialized labs where this testing might be available. Acquired में you have APLA, definitely should be high on cards. PNH testing for underlying myeloproliferative neoplasm. ICU setting है तो आपको hit and hit induced thrombosis के बारे में ख्याल रखना है. So since I'm a lab person, I think we cannot do the topic is approach to thrombophilia, but I would like to briefly discuss, maybe in the next 4-5 slides, what are basically the principles of testing this protein CS, etc. And a number of automated platforms are available. So these are not manual tests, largely automated tests. And I'll talk about the basic principles of these 5 parameters. So protein C, if you look at the basics, it is said that the deficiency can be classified as type 1 or type 2A and type 2B. Type 1 is a quantitative defect, so both antigen levels and the activity are reduced. This is something like 1 milligram जैसे हम बात करते हैं. Type 2 में the antigen levels are normal, but the activity is reduced. So majority of the defects are type 1 defects, and the figure is just summarizing like how protein C acts. So protein C, as मैंने पहले बताया था, in the presence of thrombin and thrombomodulin, protein C gets converted into its activated form and kind of leaves factor 8A and 5A, because of which this 10A and prothrombinase will not work. So क्या होगा basically आपका clotting time यानी कि prolong हो जाएगा. So this is a kind of principle for a clot-based test, but chromogenic testing is more recommended for protein C now. In the clot-based test, you will add the patient plasma with protein C from which has the protein C whatever levels it has. You add phospholipids, the contact activator, and a protein C activator, which is usually a snake venom. So the snake venom will activate protein C. So protein C will act upon factor 5 and factor 8 and delay the clotting time, right? So the time to clot which is prolonged is proportionate to the protein C which is there in the patient's plasma. Or what you can also do is that you can do a chromogenic assay. In chromogenic assay, again you have the same things. Your protein C will get activated. Once it is activated, it will act on a substrate and cleave the paramicroadenine group which is there on the substrate, and subsequently color will be produced. So कितना substrate पे ये काम करेगा, कितना protein C activate हुआ है, that color which is produced is proportionate to the amount of protein C which is initially present in the sample. So you have a clot based assay or you have a chromogenic assay, and a chromogenic assay is the one which is recommended. The normal reference range is 70 to 140%. Similarly for protein S, you have a type 1, 2A and a 2B kind of a defect. In type 1, again your antigen is reduced and your activity is reduced in concordance. In type 2A, your antigen is normal but your activity is reduced. There is one important thing to highlight in protein S, that protein S जो है दो forms में exist करता है, एक free form में and the other which is bound to the C4BP. So the bound form is the inactive form and the free form basically is the active form. So हम जब भी किसी तरह की testing के बारे में बात कर रहे हैं, we are talking about the free protein. We are more interested in the free protein S levels, and so our testing is like targeted towards identifying the how much amount of free PS is there. So इसलिए अगर आप clot based assay नहीं भी करते हो and if you do a free protein S antigenic assay, that also does not usually miss out on any kind of a protein S deficiency. So the principle is something like this, that you have a latex particle with monoclonal antibody against the protein S. You incubate that with the antigen or the protein S which is there in the patient plasma. जितना binding होगा, उतना turbidity होगा, उतना आपका light absorption proportionate होगा. So this is how your protein S antigenic testing is being done. I have purposefully removed the plot-based slide, but again, if it is done, it is on a similar manner as we do for protein C. So there are the levels are different between females and males, and 55 to 120% or 70 to 140 is roughly the range. And it is said that the free protein S levels increase with age. As protein C and as we have seen for protein S, similarly antithrombin may be type 1, type 2 defect होता है. Type 1 is quantitative and type 2 is qualitative, and 2 is further divided into 2A, 2B and 2C depending upon the type of mutation, underlying mutation of the site which is there. क्योंकि antithrombin को काम करने के लिए thrombin से bind करना है, heparin से bind करना है, and there can be a mutation in both the heparin as well as the thrombin binding site. So these are the corresponding lab tests that in type 1, which is a quantitative defect, both the cofactor SA levels would be low as well as the antigen would be low. But when there is a qualitative defect, naturally there will be a discordance between the cofactor SA and the antigen levels. So testing का principle इसमें क्या है? You add, this is the patient sample plasma of the patient which has antithrombin levels. You add a lot of heparin to it because heparin is required to activate antithrombin. So this antithrombin when it combines with heparin, then it can neutralize factor 10A. So जितना भी factor 10A neutralize होता चला जाएगा, उतना ही कम वो अपने substrate पे act कर पाएगा और उतना ही कम product बनेगा, and vice versa. So अगर antithrombin कम होगा, तो 10A neutralize नहीं हो पाएगा, जितना ज़्यादा 10A होगा, उतना ज़्यादा color आ जाएगा, right? So this is how the chromogenic testing is being done for antithrombin. And again, there are a number of factors which affect the clot-based testing for protein C as antithrombin. इसीलिए ज़्यादातर अब हम लोग we are moving to more stable ways of testing, that is either the chromogenic testing or the antigen testing, जैसा हमने free protein S के लिए किया था. We should be aware that there are a number of acquired states because of which we can have alterations in the level of protein C and S, like क्योंकि ये दोनों vitamin K dependent proteins हैं. So if there is a vitamin K deficiency or if there is a vitamin K anticoagulant therapy ongoing, if there is a liver disease, if there is a DIC, if there is a fresh thrombosis, nephrotic syndrome, infections, drugs, etc., then in states maybe we can falsely have low lab results of protein C, S and even antithrombin. So it is important to have a clear clinical situation when the sampling has been done, and it is very common कि हमारे पास अगर आप लैब में रेगुलेट नहीं करते हो तो इट इज वेरी कॉमन कि एक्यूट स्टेज में आपके पास सैंपल आया तो अभी फ्रेश डीआईसी हुआ है, कंजम्पशन हुआ है, तो लेवल्स लो आ सकते हैं. एंड अगर पेशेंट विटामिन के एंटीकोगुलेंट पर है तो अगेन योर टेस्ट रिजल्ट्स कैन बी एब्नॉर्मल. सो अवेयरनेस ऑफ दीस थिंग्स इज वेरी इंपॉर्टेंट, दैट जब हाउ टू इंटरप्रेट द रिजल्ट्स व्हेन इफ यू डोंट नो द बैकग्राउंड. सो अनफॉर्चुनेटली इवन आफ्टर बीइंग इन अ टर्शियरी केयर सेंटर लाइक एससीबीजाई, फ्रीक्वेंटली हमारे पास हिस्ट्री बहुत डिटेल नहीं होती है एंड कई बार एक्यूट स्टेज में भी हमारे पास सैंपल आता है. सो व्हेन वी गेट एन एब्नॉर्मल रिपोर्ट, व्हाट वी से इज दैट ये हम राइटर लिखते हैं कि प्लीज नोट that the protein C level is this much. Suppose it is reduced like 10% or 20%, but please reduce that if sampling has been done in an acute stage, or if the patient is on any kind of anticoagulant therapy, then the results are likely to be erroneous, and a fresh testing is required after maybe at least 3 to 6 months of the 3 to 4 weeks of the stopping of the anticoagulant therapy. Assuming कि naturally वो अपना कोर्स कंप्लीट कराने के बाद ही अब हमारे पास दोबारा टेस्टिंग के लिए भेजेगा. Except for this situation, that is neonatal purpura fulminans, which is a rare life-threatening condition where there can be a homozygous or a heterozygous protein C or S deficiency. Clinically, it will present like a acute DIC with a lot of strain, microvascular necrosis, and thrombosis. If other clinically छोटा बच्चा है, age of presentation is usually as an indicates in the neonates. If this is what is clinically suspected, then you can go ahead and do a protein C or S deficiency testing. And this is a case which was referred to us from KGMU for testing, and thankful to the resident who shared the photographs with us. And in the next case, the protein C level was less than 3%, and it was consistent with protein C deficiency. So ideally, this situation में though this is an acute event, and हम मना करते हैं acute event में testing के लिए, but this is one rare situation where you should test and you can help in establishing the diagnosis. Protein C concentrates are available if it is a protein C deficiency, or FFP can be given. And क्योंकि warfarin induced होता है because warfarin is a vitamin K antagonist, so that is why warfarin is to be avoided in these situations. So this is a perfect example where protein C S deficiency can immediately clinically impact your treatment. Factor V latent is better than doing an APCR, और मैंने purposefully APCR इसीलिए दिखाया भी नहीं because frankly if you ask me lab testing अगर हम बात करें तो maybe a 1 hour class on just lab testing is required, but since I thought these are the common thrombophilic states which we talk about when we talk about thrombophilia, so it is worthwhile that the audience should know कि protein C S और antithrombin हमारे coagulation based testing है. Factor V latent के लिए usually do a molecular testing. There are multiple point mutations because of which this factor V cleavage will not occur, and there is a resistance to activated protein C. So factor V latent जो है वो हमारा specifically is for the mutation in the nucleotide 1691 in the factor V gene where there is a change in the 506 amino acid. And this is how we do it in our lab, that is by an ARMS PCR. So if you look at the, we have internal controls, and the first lane is indicating the presence or absence of a normal allele, and the second lane is representing the presence or absence of a mutant allele. So in the first lane, we can see that we have a heterozygous pattern, that is like there is an amplification in the normal lane as well as an amplification in the mutant allele. So this patient is basically heterozygous for factor V latent mutation, whereas this patient is negative. So lane 1 and probably case 1 and case 3 हमारे जो है ये positive है, heterozygous, whereas these patients are negative, and then this is our base 50 base pair ladder. We can also do an RFLP, you can go ahead and do sequencing if you want for unknown polymorphisms. There are other factor V mutations also known as like factor V Cambridge, Hong Kong, etc. So factor V latent अगर हम देखें तो probably heterozygous state is one of the commonest thrombophilic state जो हमें मिल जाती है. The relative risk of recurrence of VTE in a factor V is almost 70 to 80 times as compared to a normal healthy control. Approximately 20% patients with the first unprovoked episode of VTE are found to be heterozygous carriers of factor V latent. I think we have also done almost 1500 or plus screening in the past 5-6 years, and we have hardly 1 or 2 homozygous patients, and जितने भी हम देखते हैं ज़्यादातर heterozygous आते हैं. And I think that is all. So, but heterozygous state does not determine whether आपके treatment में आपको कुछ change करना है. It's only probably the homozygous state which will dictate कि your thrombophilia management would be extended or your anticoagulant duration would be extended. Similarly, prothrombin gene mutation, this is actually a polymorphism, which is a gain of function mutation because of which the plasma prothrombin levels are very high, and because of this high levels, there is a prothrombotic state. It is supposed to be the second most common cause of inherited thrombophilia in the Western literature, but however, the prevalence in the Asian population is low. So ये जो हमारा thrombin है, इस photograph में just shown that this is one of the main villain भी है और hero भी है, and and you can see that it is activating so many factors, and also some inhibitors like जो fibrinolysis inhibitors है उसको भी activate करता है. So अगर इसका level बढ़ जाता है तो कितना ज़्यादा procoagulant state हो जाएगा body में. So I'll not spend much time talking about the fibrinolytic pathway, not because कि मतलब 2-3 reasons है कि मुझे ही कम आता है, दूसरा ये कि ये होता भी कम है, तीसरा ये है very few labs जो इसको testing करते हैं. So basically, what I just want to highlight is that if there is an imbalance between the coagulation cascade and the fibrinolytic pathway, इसमें कि हमारा plasminogen activator inhibitor 1, antiplasmin, TFPI, tissue plasminogen activator, इन सबका अगर कोई भी level में abnormality होती है, then that can also lead to a thrombotic state. It is not commonly recommended also to go ahead and test for these. ऐसा मैंने किसी भी guidelines में भी नहीं पढ़ा. जितने भी guidelines में inherited thrombophilia testing लिखा है, they're probably largely aimed at prothrombin gene. And if you have the facility, if you have a system in your lab to go ahead and test for this, very good. Probably you should go and test. So how do you test? इनके अपने हर protein के अपने या तो antigenic assays हैं, या chromogenic assays हैं, या functional assays हैं. Or what you can more commonly now maybe use is the global tests of hemostasis. But again, I would say though I did initially put a few slides on the role of global tests of hemostasis in thrombophilia, but that has also not really come in a big way which will help the clinician to take a call on anything. ऐसा नहीं कि मेरा अगर 10 या 10 से किसी में thrombophilic state आ रही है तो अभी we are still not clear how to use that information in patient management or diagnosis. So there is still a slide. So these are the global tests for which can be done or which are normally done in coagulation, that is viscoelastic assays, TEG, ROTEM, thrombin generation, fibrin generation tests. They are an important tool for hypercoagulation diagnostics, but they have still not come in clinical use जैसा मैंने बताया because there is a lack of standardization. There are different assays and different modifications in each assay because of which their sensitivity and specificity for each pathology is also different. So it still remains to be explored how can they really be used in routine clinical practice for clinical decision making. So this is kind of end of part 1 or the inherited causes, and let us see what did we learn for our case scenarios. So the case scenario 1 was clear कि provoked thrombosis था in a setting of major pelvic fracture, इसलिए हमने कोई testing नहीं करी. Case scenario 2 is a 24-year-old female जिसमें she is pregnant and she developed a DVT. She started on anticoagulation. So thrombophilia testing करनी है हमें, yes, it is as per the ASH guidelines, it is recommended. So pregnancy is considered as a minor provoking risk factor. So invariably treatment में तो भी आप उसको anticoagulation दोगे, but you will go ahead and do a thrombophilia testing. And supposedly if you do get a deficiency of any of these natural anticoagulants like protein C or S, as per the recommendations. So I put this as per the recommendation because I would really like to ask Mukul what he would do in this situation. It is the recommendation say that अगर thrombophilia testing में आपके पास कोई ऐसा risk factor identify हो जाता है, so that means this patient should receive extended anticoagulant therapy. And if in fact if she is pregnant again, then at that time during her pregnancy also she will need anticoagulant therapy. Invariably, वो तो मतलब अगर ये नहीं भी positive आता protein C deficiency, तो भी मेरी understanding है कि even in her next pregnancy she will still need some anticoagulation to ensure that she doesn't develop this kind of an episode. So case scenario 3 was a 25-year-old male with breathlessness, chest pain, and as I said, acute PT was confirmed on CT pulmonary angiography. So the anticoagulation treatment was started, and what to do further, test or not to test. So if you see this is a young male with unprovoked thrombosis, so thrombophilia testing, yes, thrombophilia testing should be done. The baseline parameters we can see that acute event है तो PT थोड़ा prolonged है, APTT marginally prolonged है, D-dimer is positive. अभी आपको acute PT हुआ है इसलिए your D-dimer naturally will come out to be positive. FDP is positive. So this is the basic investigations. And since he is a young patient, so I would like to go ahead for thrombophilia testing. Frankly, if you ask me, I'm not really trying to work up for inherited thrombophilia. I'm rather actually trying to work up for some acquired thrombophilic states. So as I said, young male unprovoked thrombosis, and we are not sure what was the cause. So this needs to be worked up further. Certified latent mutation हमने किया, which was amphicia based in our lab, is negative. Any kind of antithrombin protein S deficiency अभी acute stage है, इसलिए हम नहीं करेंगे. हमने लेकिन क्या और किया, हमने APLA वर्कअप किया and anti-beta 2 GP1 antibody is positive, anti-cardiolipin is positive, and again on repeating it is positive. So this patient is basically a case of LA testing हमने acute stage था, इसलिए उस समय नहीं किया. It was done later on when there was a break given in the anticoagulation stage, and LA positive भी आया. You did both your DRV screen as well as the control, and your ratio of more than 1.2 is considered positive. So this patient is basically a case of primary antiphospholipid antibody syndrome with acute pulmonary thromboembolism. So ये young patient था जिसमें unprovoked thrombosis थी, जिसमें हमने acquired thrombophilic state के लिए वर्कअप किया और inherited के लिए भी हम बाद में करना चाहें तो कर सकते हैं. But क्योंकि इसमें why is it important to test for antiphospholipid syndrome? Because in these patients they are supposed to stay on vitamin K antagonist, that is warfarin as a treatment of choice. आपका drug effect हुआ, ठीक है, आप इनको डोएक्स पे नहीं लोगे. Secondly, the duration of your anticoagulation is not 3 to 6 months जो हम routinely हर other thrombosis के लिए करते हैं. It is usually lifelong, right? So यहाँ आपकी testing ने clinically patient के management को impact किया. That is why testing in a young patient with unprovoked thrombosis is strongly recommended. The case scenario 4, जो पहले नहीं था, नया case scenario आया. You have a 45-year-old male with abdominal pain, ascites, hepatomegaly. CT scan showed venous thrombosis in the IVC and a partial thrombosis in the superior mesenteric vein. There is no other past medical history. Clinical diagnosis is Budd-Chiari syndrome, and a right hepatic vein recanalization done and anticoagulation started. So इस ऐसे situation में do you do thrombophilia testing? Yes, you need to do thrombophilia testing. The CBC showed a hemoglobin of 14.5, platelet 4 lakhs, and TLC 11,000. And बाकी जो routine था वो negative है, hepatitis APLA negative है. So this kind of a patient can turn out to be PNH positive. Right? This is how you can even in an acute stage you can go ahead and do a flow cytometry and identify your clone size. ऐसा बोलते हैं कि more than 50% clone size होता है अगर PNH में in the neutrophils, and the risk of thrombosis is high. This is a reference from Professor Jasmina Ahluwalia, where they have otherwise studied that in the Asian population, PNH is a rare cause of thrombosis for intra-abdominal veins in ethnic Indian population. They prospectively screened 142 patients with intra-abdominal thrombosis. Only 2 patients had large clones, and other risk factors rather which they found was deficiency of protein S in 13.4% patients, protein C deficiency in 4.9% patients, antithrombin deficiency in 2.1, and factor V mutation in 1.4% patients. Additionally, they also found anti-beta glycoprotein 1 deficiency in antigenic positivity for 9.2%, anti-cardiolipin antibodies in 1.4, and LA in 0.7%. So this is just to bring forward कि खाली PNH ही वो study कर रहे थे, but these are the other things which these patients also came out to be positive for. And in general हमारा अपना ऑब्जर्वेशन भी है कि थ्रोम्बोफिलिया टेस्टिंग में हमारे बहुत ही कम केसेस हैं जिसमें थ्रोम्बोसिस में हमने पीएनएच बड़ा क्लिक दिया हो. देयर माइट बी मेबी 1 or 2 केसेस इन द पास्ट सो मेनी इयर्स. और दिस पेशेंट जैसा मैंने बताया, इवन Budd-Chiari syndrome में ये दो चीजें हैं जिनके लिए आप नॉर्मली टेस्ट कराते ही हो. सो अगेन वी डू JAK2 testing by RT-PCR in our lab. You can do by RT-PCR, you can go ahead by sequencing or RT-PCR and things like that. So this is the pattern for a negative patient. This is the pattern which we get for a homozygous. The mutant, we only have the mutant band, whereas in a heterozygous state we have both mutant as well as the normal wild type band. So this is the study of JAK2 mutations. I think this is an Indian study, I forgotten. And this was a group of 321 patients with venous thromboembolism, out of which 19 cases were JAK2 mutation positive, and these included DVT 3%, Budd-Chiari syndrome 8.8%, portal vein thrombosis 5%, and CVT 3%. So this is just to highlight that even JAK2 is an important test which should be done if you are again seeing a patient in a specific scenario. And let me also make it very clear at this time point कि ये वाला JAK2 में जरूरी नहीं है कि आपको thrombocytosis और hemoglobin cutoff of more than 16.5 मिले. So frequently we have seen that these JAK2 positive patients may or may not have meet those criteria. So this is kind of a, I don't know, is it because of the disease physiology or because of the splenomegaly or whatever. But हमारे वो hematological cutoffs जो PV और ET के लिए हैं, ये जरूरी नहीं कि ये JAK2 को meet करे. So for the audience who has already slept off, I believe this was a very long talk. I might have 3 or 4 slides only more. What is otherwise the role of genetic testing in thrombophilia? So gene panels are commercially available, but as per that British guidelines, testing should typically be targeted for those young patients with less than 40, where you have a spontaneous thrombosis or a thrombosis which is associated with weak environmental risk factors, or which is also present in at least one first degree relative. Testing should only be used if it will impact clinical management. And then again, ये testing order करना है कि नहीं, ये मेरे purview से ज़्यादा, it is more on the treating physician who needs to decide. And otherwise, it is written that if you go by the recommendations, so genetic testing to predict first episode of venous thrombosis is not recommended. मतलब अगर first degree relative किसी को thrombo ऐसा risk factor देखा गया है, तो उसका ये मतलब नहीं कि आप उसके relatives को you start testing for the risk of venous thrombosis, because कोई direct correlation is not established so far. But I still remember again 1 or 2 cases जिसका हमने protein C functional assays कराए थे, and it was normal. And Dr. Anshul came back to me and said कि हमने इसका gene testing कराया था, and we found that there is a recurrent VTE in this patient, इसलिए हमने genetic testing कराया, and genetically there is presence of a heterozygous protein S mutation. So अब इसका क्या करना है? So I'm not sure if I was able to answer Anshul correctly, but I feel clinically अगर आपके पास invariably recurrent VTE का patient है, तो अगर वो genetic testing में positive आएगा भी या नहीं भी आएगा, तो मेरा management again I would bank on Mukul to support me कि मेरे management में कितना difference होगा ऐसे patient को जिसको recurrent VTE है irrespective of the underlying cause, right? So I don't know. I hope people who are listening to me are getting the message which I want to pass on. और मैं आपको confuse नहीं किया है. So some recommendations from the article जो मैंने बताया from that Journal of Hematology. So these are things which are not recommended. Thrombophilia testing in the presence of major risk factors, thrombophilia testing during VTE, thrombophilia testing of the first degree relative with a history of VTE, testing for heritable thrombophilia in a patient with stroke, क्योंकि ये भी कई बार लैब में रेफर हो जाता है कि MI हुआ है, thrombophilia testing कर दो, उसका कोई मतलब नहीं है. And in women who have had previous unprovoked or estrogen provoked VTE, routine thromboprophylaxis will be required throughout pregnancy and peritoneum irrespective of the presence or absence of a risk factor. So testing in these situations is usually not recommended. So bottom line करना ही कहाँ है? Testing usually should be done when it is likely to alter the management. And then common tests are like PNA, JAK2, APLA in patients who come to you with thrombosis at unusual sites and may or may not have a normal or abnormal hematological parameter to support this. Or even if you have an unprovoked arterial thrombosis, because these 3 conditions need not necessarily present with the venous thrombosis, they can come to you with arterial thrombosis also. And lastly, neonates and children who have purpura fulminans is suspected. So this purpura fulminans can be due to congenital protein C deficiency, or it can be idiopathic, or it can be secondary to an underlying infection. Eventually इन सारी conditions में होता क्या है कि protein C और S जो है का level decrease हो जाता है. So आप इसलिए इन acute stages में आप protein C S deficiency के लिए workup कर सकते हो, and if it comes out low, it is supporting your clinical diagnosis. So in the lower box, testing is recommended for all these states. So again, this is just a summary of what I have been speaking so far. First episode of thrombosis, And thrombophilia testing is not required if it was a provoked thrombosis in the presence of very strong risk factors or known risk factors. Like अगर आपको पता ही है कि इसको myeloma है, ये drug induced हो सकता है या leukemia induced हो सकता है, तो उसमें testing का कोई मतलब नहीं है. But if it is an unprovoked thrombosis or it is a provoked thrombosis in the presence of some weak triggers, young patient, strong family history, childbearing age, OCP लेने की वजह से हो गया, so you can go ahead and work up these patients for hereditary thrombophilia if you think it is actually going to alter your management. If it is negative for the common ones, you have the rare ones which can be looked up. But again, if you ask me कहाँ ये होता है, I'm not very sure. I don't have an answer. Then you have specific situations like portal vein thrombosis है या Budd-Chiari syndrome है, तो आप PNH कराते ही हो. ICU setting में you should suspect it. Young female, middle radicularitis, etc. Apla worker, arterial thrombosis usually secondary to hyperlipidemia, atherosclerosis, diabetes mellitus. But even in arterial thrombosis, you can work up for PNH, Apla, or JAK2. So I'd like to thank at first Dr. Jasmina, due to which I think I have whatever understanding I have of thrombophilia and the practice which they ensured कि thrombophilia testing should not be an open test. कि anybody sitting in the OPD उन्होंने form raise कर दिया. It is best that there is somebody a triage which can be done to patient से बात कर सके. We can understand when was the thrombotic event, when did it occur, what is the treatment which is ongoing, and is it right at the time now to collect all samples or not, and if not, what can be collected and what cannot be collected. Or if your clinician is very wise enough, hats off to the clinical team as well. Then this is my department and the people in the lab who are actually running all the tests. And there is Dr. Dinesh. Then we have Vishwas, Meena, and Aslam has left. And thank you so much. That is all about my understanding on the topic. खाली इतना बोला एंड में कि प्रोवोक है तो नहीं कराना है, अनप्रोवोक है और यंग है और रिकरेंट है और अनयूजुअल साइड पे है तो करा लो. थैंक यू. वाओ, मैंने पूरा 1 घंटे में खत्म कर दिया. ओवर टू यू डॉक्टर इफत. Is there anybody?
Yeah, thank you, ma'am. Thank you, ma'am, for such a nice presentation. Ma'am, may I request Dr. Mukul sir to add his expert comments on this?
Thank you, ma'am. मेरे लिए आपने कुछ नहीं छोड़ा सच में बताने के लिए. So what I will do is just re-emphasize the thing which you already told and maybe just add some cartoons and tips to it. So I hope my slides are visible.
Yes,
that's perfect. Yes, visible.
I'll say clinical perspective, but almost all the things have been told by ma'am already. So I'll just re-emphasizing again few things which we do in our practice. So the current management of thrombosis depends on two things, whether it's a provoked or unprovoked DVT. So provoked or with no transient strategy, long-term anticoagulation, usually at least 1 year of intensive anticoagulation and followed by long-term anticoagulation could be lifelong in many patients. For provoked or transient strategy, you give at least 3 months of therapy and up to 6 months of therapy. And major determinant for thrombophilia testing is risk of recurrence. Ma'am has already told that this is around 1% with the transient risk factors or provoked DVT and up to 10%. And in the first year of stopping anticoagulation, which can go up to almost 50% in 10 years with totally unprovoked DVT plus the site of DVT. I say site because clinically when the patient has a history of cortical venous thrombosis or abdominal thrombosis, at those times these are more symptomatic or risky site of rethrombosis. In those situations, you may consider anticoagulation for a longish period of time. So this has been nicely highlighted. Risk factors are recent surgery, trauma, prolonged immobilization. Usually at least 3 days of immobilization is something which is important. Surgery more with abdominal surgeries and pelvic surgeries, fractures of leg bones. So those are your major surgeries which are predisposing to DVT. Polycystictomy is not considered a surgery in such a scenario. So other risk factors are like pregnancy, HRT, OCP, anatomic risk factors like cervical rib or medicinal obstructive syndromes otherwise, or central venous exercise devices which can be risk factors for some of these patients. So these are important risk factors. So things have been said about pregnancy and OCP. Prior to last year, these was transient. These are entirely considered to be transient or provoked DVT. But last year, ASH recommended that some kind of thrombophilia testing can be helpful in these scenarios. So this is already this is based on a very weak kind of recommendation, but that has come as a recommendation for American Society of Hematology. I have to add some drugs. So there are 3 categories of drugs which are available: vitamin K antagonists like warfarin, heparins, and DOACs. So vitamin K antagonists are cheap. No, they require monitoring with PT and INA. Compliance is an issue with these drugs, and at most of the time, you require at least the patient should be in a therapeutic INA range for at least 2/3 of the period. They are better for long-term treatment and especially for Apla syndrome. Heparins are unfractionated low molecular weight of fondaparinol. Usually these are injectables, so given for short-term hospital medications and good for sick patient, hospitalized patient, and during pregnancy. During pregnancy, the other 2 anticoagulants are less preferred. DOACs, they are a good agent for most of the patient, except for Apla syndrome, except for patient of GI thrombosis with cancer, except for patient who have mechanical cardiac valves, and when the risk of bleeding is high. Because when the bleeding risk is high, we don't usually have the inhibitor for these isn't readily available with us, so the antidote is not available. That's why when the risk of bleeding is very high, you tend to prefer the other 2 agents. Advantage is that no monitoring is required, and overall, per se, they have a lower risk of rebleeding or recurrence of thrombosis. When do I consider? So this ma'am has already highlighted nicely that after 3 months you can go for population testing only. Earlier with mutation or flow-based testing or antibody-based testing. When do I consider when I have to decide the agent? So the most important indication in such a scenario is Apla syndrome. When I have to decide whether I can give DOACs or not. If Apla syndrome is present, then warfarin analogs are my long-term treatment of choice. Then atypical sites of thrombosis, planktonic, CNS. In these scenarios, your testing for PNH becomes important, testing for Apla becomes important, testing for heparin-induced thrombocytopenia and thrombosis become important. And like we heard around a month back, vaccine-induced thrombosis becomes important. And testing for MPNs. So all the 3 MPNs, JAK, PV, ET, myelofibrosis, they can present with atypical sites of thrombosis, especially planktonic. Then if there is a definite family history of thrombosis, then and a proven history of thrombosis or a thrombotic state in the patient, then you can consider that patient for a targeted testing. Suppose you have a patient whose relative is having a history of thrombosis and has been diagnosed, let's say, with protein C. So you do not consider all the thrombophilia testing, you just target a specific test for this patient. Neonatal purpura fulminans, ma'am has already highlighted for neonates. Initially, with who sick neonates who present with the purpura fulminans, protein C and SMB associated. In my practice, we are now not going for homocysteine or MTHFR testing, and of late we have also almost stopped doing prothrombin gene mutation testing because these have not been picked up at least for a reasonable amount of time I'm aware of. This is very important when definitely not to do testing. Recurrent thrombosis, no testing is required, irrespective of the cause. If the patient has a recurrence of thrombosis, this patient requires long-term, probably lifelong anticoagulation, so no need to test for any kind of thrombophilia in such a scenario. You can just check for Apla syndrome to decide on the agent. That's it. When there is a definite provoking risk factor present, we should remember in this scenario, the risk factor which is now considered to be definite is prolonged surgery or trauma or immobilization. All the others are clubbed into transient or not so convincing risk factors. And lastly, if the patient is having an active cancer or already a diagnosed case of myeloproliferative disorder, in such scenarios, I will not consider for additional testing for this patient if they have these two conditions. For pregnancy and HRT, new recommendations have come which suggest for doing testing. Although the relevance of the testing in such scenario is pretty questionable, like ma'am has already said, we are not doing it till 2023. Now, what's important is the patient develops thrombosis during pregnancy, or the patient develops thrombosis during HRT or IVF kind of things. In those scenarios, they require prophylaxis with therapeutic or prophylactic anticoagulation during next pregnancy and at least for 6 weeks postpartum. That is something which we have practiced for a long time. In the light of new recommendation, what to do if a rare thrombophilia comes up during pregnancy and diagnosed, I'm not very sure of those things, at least at present. I think that's it from my side. Thank you, ma'am, for taking the most of the gist out of my presentation, and excellent presentation from your side, ma'am. Thank you.
Thank you, Mukul, for confirming what I've already said. Because I personally feel जैसे दिनेश बोलते हैं ना कि everybody loves coagulation but nobody understands coagulation. I would say it stands more true for thrombophilia. Everybody talks about thrombophilia, but उसको समझना कि कहाँ treatment देना है और नहीं देना है और कितना लंबा देना है और कब बंद कर देना है, that is even more challenging. And actually, this pregnancy वाला point which you have pointed out is a surprise. कि according to them, कि pregnancy में you need to kind of give an indefinite anti option, but that would be very difficult to actually execute. So,
because that state is lying dormant for a long time and just activated during pregnancy, those are difficult things to say and warrant a long-term anticoagulation per se.
Yeah. So
I think over to moderators.
yeah. I think we're ready to answer all the questions now in the chat box.
Ma'am, I can see only one question in the chat box, and rest all are compliments for you both. So the question is, Dr. Shakir is asking, is it important to subclassify protein C, S, antithrombin deficiency into types?
No, it is not actually important to subclassify, but rather it is important to know that there are two different types of deficiencies which exist. And so, if you might not be reporting the antigen levels normal, whereas actually functionally आपने test ही नहीं करा and that was abnormal, so you're kind of missing out on the type 2 defect. So if you should know what kind of a lab test should be done so that you can pick up both the defects. Like as I said, free protein S is now the recommended testing for protein S deficiency rather than the functional test जो हम लोग पहले करते थे, because even free protein S antigenic level is sufficient to pick up any type 1 or type 2 defect. So this is actually more, I would feel, important to dictate and decide what is the test you are doing in your lab, and whatever way if you are able to pick up both the defects, it is good to go. It is not necessary to classify it into either one or two.
Okay, thank you. There is another question addressed to Dr. Mukul sir. How to decide vaccine-induced thrombosis?
This was something expected since the last month controversy from the AstraZeneca vaccine. So there are certain things which happen with vaccine-induced thrombosis. It occurs within the first 6 weeks of the thrombosis of the vaccine being given. Seen with some types of vaccine, not with all types of COVID vaccines. Then the pathophysiology and the course, it is kind of similar to what we see with heparin-induced thrombocytopenia. And platelet factor 4 and the PF4 is the recommended test for diagnosis of this in this setting. The site of thrombosis is pretty atypical in most of the scenarios, and the CNS and the lengthening vein thrombosis are more commonly seen in the DVT and deviant thrombosis of the legs or otherwise. In such scenarios, what you give is anticoagulation. It is recommended. You give it for at least 3 months. The choice of agents are usually DOACs or low molecular weight heparins, and warfarin analogs are not kind of very much preferred in such scenarios. The chances of recurrence are pretty low. In fact, there were studies which showed that even if you give the same vaccine again, the chances of recurrence are low. Now, if you can add anything else. Okay.
I think among the audience,
I can see a question. In APLA, if patient has thrombocytopenia, then how do you give anticoagulation?
This is, I think, again for me. आपके लिए compliments and questions हैं.
उसको पता है कि किससे पूछना है.
नहीं मैम, मुझको पता है किसको करना है. Anyway, देखो, thrombocytopenia और APLA, they can occur in less than 5% of the patient together. चाहे वो ITP के साथ associated हो या फिर APLA syndrome के साथ हो. So this combination can occur in up to 2-3% and maybe up to 5% of the patient at times. So this becomes a problematic scenario because your usual cutoff for therapeutic anticoagulation, which will be with warfarin in such a scenario, is around 50,000 platelet. Below that, it becomes problematic. We kind of give prophylactic doses of low molecular weight heparins in such scenarios up to the platelet count of 25,000. So between 25 to 50,000 prophylactic doses of heparins. Above 50,000, you give warfarin or therapeutic doses of heparins.
I think I read for in malignancies also कि आपके leukemia वगैरह में भी there is a thrombotic event and उसमें in fact thrombocytopenia ज़्यादा common होता है, तो शायद बस एक line के पता है you give a dose adjusted or a reduced dose low molecular weight heparin to strike a balance between anticoagulation and preventing the risk of bleeding. But low molecular weight.
Cancer में एक advantage है कि आप उसमें platelets transfusion करके भी आप maintain कर सकते हो high level, which is not something which you are doing with the ITP or APLA syndrome.
Right.
So that's why that cutoffs are more practice based.
So can I ask one question?
No.
Dr. Mukul.
मैंने पढ़ लिया आपका question.
My question is, we are just reviewing for CJR our thrombotic data. So whenever we give the abnormal results, it is not it is because of due to some drug during anticoagulation or due to acute phase reaction, phase of thrombosis, or even if it is not in that, especially in the cases of lupus anticoagulant, when the results are on first, it is just positive, but majority of the time they are transient. Okay, so
yes,
we have seen the positive cases. We left out the negative. We see the positive cases. Hardly out of 100 we receive only 5 or 6 requests for the repeat to confirm after 12 weeks that yes, it is positive and it is permanent, not a transient inhibitor. So what you do with that first positive report or low level of that particular factors or protein S wanted? So my question is, what do you do with those results without repeating it or confirming it again?
So, Dr. Dinesh, our practice, in fact, I can say for most of the practicing hematologists, the practice is shifting towards using DOACs more and more. When our lab gives a positive result for lupus, for APLA syndrome, in any form, be it lupus, be it with the beta-2 GPI or with the ACLA antibodies, at that point, the patient is shifted to a warfarin-based therapy. So when this patient comes to, and we label this on the file that at least one test has come out to positive, and give the patient forms for repeat testing after 3 months. Now, whether the patient, if the patient gets it done, very good. If the patient doesn't get it done, so when I see this patient after like 3 months or 4 months, and I see why this patient is on warfarin, so that is my trigger to recheck whether at any point of time was this patient tested for lupus or for APLA syndrome or not. So that is a trigger which I follow and ask my residents also to follow. That at least give the form for the 3-month testing when you get the first result, and just check why your patient is on warfarin analog in the current era.
So
Meanwhile,
actually,
we could,
yes,
please.
sir, please continue.
No, so that's what the patient on warfarin. Just check again why if the possibility of Apple syndrome being there is not has been considered or not. That's it.
So just when we discussing with the Richie and other colleagues, so we finally decide to change the format to report lupus anticoagulant. Now we give the normalized ratio. It is more than this 1.2 or whatever it is. The value comes, and we don't. If it is the first testing, we don't write it as positive. We write the note. If it is positive, it is considered as a positive. But a repeat testing after 12 weeks is advised. So we are not writing positive it because it is the first time only. So that is maybe should compel the clinician to reinsist that second testing is very important to reconfirm it is not a transit inhibitor. It is a real lupus, or it is we can now put it into the antiphosphotic syndrome category.
The problem is that what to do in between if that is only plus minus kind of a report we have.
So APLA is one thing, but the lupus anticoagulant में मुझे personally I believe that anti-cardiolipin and anti-beta 2 glycoprotein testing is more important. वो ज़्यादा consistent है और thrombosis के साथ correlation भी anti-beta 2 का ज़्यादा बताया गया है. Triple positive अगर आ जाता है, if you're able to actually document cardiolipin, anti-beta 2 और LA तीनों positive हैं, तो उसमें तो मैंने ये पढ़ा है कि triple positivity just means that the rate of recurrence is even higher now. So आपका APLA का diagnosis तो anti-cardiolipin और anti-beta 2 से ही बन गया है. LA खाली आपको सब supplement कर रहा है ये बताने में कि it is even a higher risk. So probably that is what Dinesh, जैसे मैंने I was discussing बता दूं कि ये देखो ये नई recommendation में लिखा है कि PTE अगर आ गया है तो यानी कि indefinite anticoagulation देना है. But then he said कि practically in my past 10 years there are people on my fingertips 3 or 4 जिनको मुझे मालूम है कि recurrence हुआ है. तो मैं उसकी वजह से बाकी 50 को कैसे लाइफ लॉन्ग एंटीकोगुलेशन पे डालूं. So it is just that these recommendations have to be followed carefully in light of what is practically important. जैसे जैसे मैं ये टॉक के लिए और पढ़ती जा रही थी मुझे ऐसा लगा था कि धीरे-धीरे I might know after 5 years that thrombophilia testing is now no longer recommended. आपको
more or less move towards that thing and just put thrombophilia to gauge whether it is Apple syndrome or not.
Right. क्योंकि जितने भी recommendations है ASH वाला है चाहे ACCP वाला है ये दोनों तो टेस्टिंग के बारे में ज्यादा बात ही नहीं करते हैं. वो खाली आपसे यही बात कर रहे हैं कि आपको 3 to 6 month एंटीकोगुलेशन देना है या लंबा एंटीकोगुलेशन देना है. It is only that British guidelines जो बेचारा थ्रोम्बोफिलिया टेस्टिंग पे उसने कुछ बातें लिखी तो है वरना बाकी लोगों का ये कहना है कि there is a high risk of recurrence or if it is at an unusual site in a young patient it is better to anticoagulate for a longer time irrespective of the underlying cause except जैसा इसने बताया APLA. तो maybe वो एक डिबेट का ही genuinely बहुत ही इंटरेस्टिंग टॉपिक है and we are kind of moving towards a situation जहां टेस्टिंग की इंपॉर्टेंस धीरे-धीरे कम होती जा रही है.
So just a point. So regarding APLA syndrome, where these are not positive, anti-beta 2 and anti-cardiolipin, and LA is just positive one time. So maybe and patient is putting on anticoagulant. So now the people are moving on PSPT. So that does not affect with the anticoagulation therapy. So maybe this is the fourth test which is going to come in recommendation very soon for testing for APLA, and it is showing very good results and very consistent positivity in cases of APLA syndrome.
Okay.
Even data from that AIMS, Dr. Jasmita and what's the name of that resident? I forget. The data is very promising and very nice data they have shown. Not published, unpublished, mutually discussed.
And there is question about recurrent abortion due to thrombophilia during pregnancy.
ये भी तुम्ही को बताना है. I believe इसमें low molecular weight heparin तुमने बोला ही है कि 6 हफ्ते बाद तक तुम देते हो. But thrombophilia testing as per the ASH guidelines at least for pregnancy में तो उन्होंने लिखा है कि that you should do a thrombophilia testing. So I believe अगर postpartum है तो भी that guidelines probably would still be there. या will hold true. And as per their guidelines it is said कि अगर positive आता है कुछ thrombophilia testing में then you have to anticoagulate the patient for a indefinite period. So I'm not sure about the indefinite period but at least you will anticoagulate the patient. And अगर patient दोबारा फिर से pregnant होती है तो during pregnancy you will actually have to anticoagulate the patient during pregnancy and even in the postpartum period. Practically this is important. और अगर testing negative आती है तो भी यही करना है.
At least during the 9 months of pregnancy and 6 weeks postpartum anticoagulation. Other acute thrombosis है, active thrombosis है तो therapeutic dose. Otherwise next pregnancy में prophylactic dose. And warfarin is not recommended. DOACs are not recommended during pregnancy. This lady has to take around 11 months of injectables.
So another important thing regarding recurrent pregnancy in abortion in pregnancy. Apart from these tests, we should also test for factor 13, factor 12, factor 11, factor 2, and for the dysprosinemia because they are the common causes for recurrent abortion in pregnancy. Apart from all those things.
And please remember that hematology contributes very little to abortions during pregnancy. There are host of many other gynecological causes and obstetric causes for recurrent losses. So the contribution of hematology to abortions and bad obstetric history is not that very high. Whatever conditions we are talking about, these are rarer conditions.
I think
there is another question that says that should we go for thrombophilia testing postpartum DVT? Yes, it has been covered in these slides.
Postpartum DVT is equivalent to pregnancy DVT.
This has been covered.
Within 6 weeks.
Yes, ma'am. Now there are no more questions. So thank you very much,
Thank you.
sir and ma'am.
And
And
thank you,
Thank you, ma'am. Thank you,
Dinesh.
Thank you, ma'am. Thank you, ma'am.